The aortic and mitral valves are most commonly affected. The onset of mitral regurg can actually be quite sudden. And if this progresses to heart failure, the patient usually goes straight to surgery to get the valve repaired or replaced. Even after the infection passes, patients can be left with a chronically regurgitant mitral valve. Okay, each of the valvular disorders we've covered so far is an example of primary mitral regurg. In other words, the abnormality lies within the components of the valve apparatus itself, either the leaflets or chordae tendineae or annulus. Compare this to secondary mitral regurg, which is caused by abnormalities in the surrounding heart structures, not the valve. This is seen in left-sided heart failure, for example. Take a look. You see that floppy, failing heart balloon? That's a recurring sketchy symbol for heart failure. And in volume-overloaded hearts specifically, the myocardium undergoes eccentric hypertrophy, leading to a big, dilated chamber. This stretches open that mitral valve annulus to cause regurg. A similar process occurs in the setting of dilated cardiomyopathy. Yup. Whether it's a sack race, bag of birdseed, or hot air balloon sandbag, dilated cardiomyopathy is always symbolized by a floppy heart bag. So again, let that basket remind you of the mitral valve annulus getting stretched open by the chambers that surround it. In these past few examples of primary and secondary valve disorders, mitral regurgitation often follows a course of chronic progression. This means that the left atrium has time to adapt. Take a look at the enlarged chamber of that hot air balloon that's in the middle of taking off. Our recurring chronic grandfather clock should remind you that this is chronic mitral regurg we're talking about here, and it causes the left atrium to dilate and undergo hypertrophy. As the atrium takes on more blood, less pressure is transmitted back to the pulmonary circuit. This is why chronic mitral regurg usually will not cause significant pulmonary edema. We've subtly highlighted a couple other hemodynamic principles here as well. First of all, when disease takes a chronic course, mitral regurgitation reaches what's called a compensated state. In other words, we have a preserved cardiac output. In the hyperacute setting, the heart had no time to react, and cardiac output plummeted. This time, the heart reaches an equilibrium that allows it to maintain forward stroke volume. So let that undying flame remind you that cardiac output is firing away and doing just fine. This requires a chronically increased ejection fraction, however. In order to maintain cardiac output, the ventricle has to eject an adequate amount of blood into the systemic circuit, even though a portion of that stroke volume is wasted through a regurgitant valve. An increased ejection fraction will make up the difference. And, as always, we have a fraction raised up in the air. A fraction of pi, that is. In compensated mitral regurg, then, that left ventricle is dealing with chronically increased ejection duties and volume overload. That means chronically elevated preload in that chamber. And you know that means we need to draw someone pulling on a load. It's the sketchy way. So we've added a gesture here, pulling on that balloon, trying to keep it from taking off. This chronic volume overload, however, causes the left ventricle to undergo eccentric hypertrophy. This is when the myocytes grow lengthwise in series, causing the chamber to grow larger. This lengthwise addition of sarcomeres is depicted by that extended myocardial ribbon. Just like in our heart failure sketch, however, once eccentric hypertrophy sets in, there's no happy ending. Eventually, the heart just can't take it anymore. It's too much pressure and volume in the chamber to contend with. And as cardiac output falls, your patient with chronic mitral regurg will begin to manifest symptoms of heart failure. Well, that was a downer. How about I cheer you up by talking about a few fun heart sounds you'll find on physical exam? The murmur of mitral regurg is described as a blowing, holosystolic murmur heard best over the cardiac apex with radiation to the axilla. And we've shown that here. We've got our usual systolic spray to denote a systolic murmur. And if clenching a gesture in your armpit doesn't remind you of radiation to the axilla, I don't know what will. We'll even add a subtle and totally 90s hologram sheen to that gesture jump club sign. That's holographic for holosystolic, meaning the murmur is heard throughout systole. See what I mean? Dilation of the left ventricle, as we mentioned before, is a compensatory mechanism that helps maintain cardiac output. This leads to an S3 gallop as blood rushes into that dilated floppy ventricle. In fact, the most reliable auscultatory finding indicating severe mitral regurg is a prominent S3. It comes right after S2. You hear it? Since it's caused by blood sloshing into a floppy chamber, just remember the phrase sloshingen, sloshingen, sloshingen. The holosystolic murmur of mitral regurg is actually less reliable for estimating the severity, as a wider regurgitant path causes a softer murmur. By the way, remember the mitral regurg caused by heart failure? It occurs when the mitral annulus is stretched open by volume overload. It makes sense then that if you fix the volume overload with diuretics, not only do their heart failure symptoms go away, their murmur goes away too. Less volume means a smaller chamber and a smaller mitral annulus. Therefore, no more regurg and no more murmur. Just think of this jovial jester here, diuresing all over himself with glee as he squeezes shut that mitral hat of his. All right, let's wrap up this sketch with a quick discussion of the specific exam findings associated with mitral valve prolapse. Remember that one? It involves the mitral leaflets billowing up like a parachute into the left atrium. It's usually caused by myxomatous degeneration of the mitral valve, and it's the most common cause of chronic mitral regurgitation. Well, I first just want to mention that the same scenario can occur in a variety of connective tissue disorders, including Ehlers-Danlos, Marfan syndrome, and osteogenesis imperfecta. This Marfan Martian here will embody all of these disorders. He's even donned the myxomatous mixer to remind you that you'll find the same basic pathology of myxomatous degeneration, which really just means some kind of connective tissue degeneration. Yeah, we do every kind of extreme sport here. Parasailing, hang gliding, blender. So why not ziplining? The posts are labeled S1 and S2 to remind you that the murmur associated with mitral valve prolapse can be heard during systole, in between the S1 and S2 heart sounds. Hear it? What you really need to listen for is that classic mid-systolic click. See that guy clipping himself onto the rope with his carabiner? Click. That click is caused by floppy stretch chordae snapping taut as the valves prolapse through the mitral annulus. A regurgitant murmur may also be present, so also listen for the typical holosystolic blowing murmur best heard over the apex and radiating to the axilla. Just like before, different maneuvers affecting preload and afterload can influence the intensity of the mitral prolapse murmur. Isn't that fun? Decreasing preload, for example, by Valsalva or by standing from a sitting position, will shorten the length of systole and cause a click to move closer to S1. That's why, close to the S1 post, we've got a nervous customer standing and maneuvering a Valsalva like none other. It's okay, dude. Just make like David Lee Roth and run with the devil. Right over to the other side. What? What did you think I was gonna say? Anyways, anything that increases heart rate, like anxiety or exercise, will also have the same effect of moving that click closer to S1. This time it's because of a decreased diastolic filling time. See that elevated heart watch? That means tachycardia in our secret sketchy language. So we decreased preload. Now let's increase preload. Take a look at the picture-perfect landing technique on display here. You've got to raise those legs and then squat at the finish. A supine leg raise and squatting are both easy ways to increase venous return, increase preload, and prolong the length of systole. This moves the click closer to S2. Sustained hand grip can do the same thing, though this works by increasing afterload and slightly impeding left ventricular emptying, thus lengthening systole. Just remember that you'll have to prolong that hand grip if you're going to be able to zipline all the way to S2. All right, that about sums up the mitral valve. Let's see. We've covered rheumatic heart disease causing mitral stenosis, and now all this floppy mitral regurg jester juice. It's time to put on our princess hats and head on over to the aortic valve.